Hello again. Welcome to our session of digital slide review and sign out. I'm Dr. Lewis Hassel, and I'm coming to you from the University of Oklahoma Health Sciences Center. Our program is part of the Digital Anatomic Pathology Academy, which is a joint venture with the Digital Pathology Association and our great friends at Path Presenter. Our cases come from both the archives of Path Presenter and the Digital Pathology Association, as well as from my own practice at the University of Oklahoma. Our case today is a fairly frequently encountered challenge, maybe not so much a challenge diagnostically as it is clinically in some circumstances. It's a 35-year-old woman who has been having cyclic pelvic pain, and recently was also noted to have a little bit of blood in her stool, which raised some concerns, both from her gynecologist and from her other physicians. So as we think about things that can cause cyclic pelvic pain, well, of course, regular menstruation can be painful and be associated with some cramps that can be quite variable and quite severe in some circumstances. These are often attributed to various intrinsic factors involved with contraction and the tissue breakdown associated with menstruation. They may be more pronounced in women who have adenomyosis, so-called extension of the endometrial tissue into the deeper portions of the myometrium. And they're also known to occur in endometriosis. Other causes, of course, are described, but these would be the most frequently encountered ones that are associated with the hormonal cycling of physiologic adult women. The management of this situation, and I'm not an expert in this, but from reliable reviews in the literature, of course, follows the process that we do in much of clinical medicine, where you examine the patient, take the history, and then do other testing that may be pertinent. In this case, pelvic ultrasound is one of the more frequently used evaluations. And as you can see, the various flowcharts here can include integration of other specialists. If, as in our case, there's a GI tract potential involvement, and potentially in certain circumstances, either medical management or potentially surgical management, depending on the findings from the studies and the history. Of course, medications can play a role in evaluating that and may merit a trial prior to going to surgical or other management situations. So I just wanted to emphasize that this is a rather complex management challenge, but one which can be followed rationally to treat the patient's symptoms and help them to resolve the issue, or cope with it and manage it in a more successful way. When in our particular patient, GI endoscopy was performed, leading to the production of a couple of biopsies. And as we note here, there's one sort of more conventional polypoid lesion here with sort of serrated architecture, compatible with either a hyperplastic or serrated polyp. But the more pertinent findings were in several of the other fragments, where in addition to conventional colonic type glands, we had a number of quite dilated glands that seemed to be associated with a somewhat bluish stroma, and were architecturally altered from the conventional colonic glands, more cytoplasmic eosinophilia, and a little bit just not fitting with what we would usually think of at the GI tract in terms of polyps. So looking at these, there's some admixed colonic tissues, but then there's these other glands that have no mucin and have a slightly different cytoplasmic character, a little bit of apical budding associated with some of these, and then this surrounding stroma. Another of the fragments here, you can see it involved this one as well. And this last fragment up here that was nicely highlighted also showed a few of these scattered glands deep to the muscularis mucosa. Here, as you can nicely see, this delimiting muscularis mucosa, and these glands are beneath that with some associated cellular stroma. So the diagnosis of endometriosis is contingent upon demonstrating both glands of endometrial type and endometrial type stroma. Now, in some circumstances, immunohistochemistry can be useful in that setting. And this is a nice example where a CD10 stain shows essentially no staining of the normal enteric lamina propria or muscularis. But here, amongst these somewhat atypical or architecturally altered glands, we have a pretty strong reactivity around these glands that would be consistent with, in this setting, the diagnosis of endometriosis. So where do we see endometriosis? Well, this can affect a variety of sites, which is part of what makes it both challenging to treat as well as to diagnose. So we mentioned here bowel involvement. The appendix also frequently is involved. More commonly, however, the fallopian tube or ovarian serosa surfaces can be involved, sometimes the surface of the uterus, very often the peritoneal surfaces surrounding the uterus, the cul-de-sac, anteriorly or posteriorly, the uterosacral ligaments, and these other pelvic tissues. But in addition to these, occasionally other sites will be involved as well. The skin, the bone, even on occasion, I can remember one very notable case of a CPC from the Mass General where it was the spinal cord that was involved. So obviously, depending on the site that's involved and the nature of the involvement, these can present potentially serious problems. So just to illustrate from the relatively minor to the more serious, here's a section of ovary with some ovarian cysts, a little corpus luteum that's resolving. And over here, we have a little fragment of glandular tissue dilated, a little bit of surrounding stroma that represents endometriosis. Now, as endometriosis persists and develops in the ovary, it can begin to develop scarring. You can get cystic changes. If there's no space to release the hemorrhage, that can become dilated and become a so-called chocolate cyst of the ovary, presenting a mass and creating some further problems. Here we've mentioned the appendix. That also can be involved, as you see here on the serosa down here. We have a nice little cluster of irregularly shaped glands with a little bit of stroma surrounding them, and this characteristic hemorrhage that highlights the area and makes it visible at laparoscopy as well. And the involvement in the appendix can be very superficial on the serosa like this, or involving the muscularis and even the mucosa, mimicking at times acute appendicitis. Endometrial glands and stroma are required for the diagnosis. In addition to CD10 stains, sometimes progesterone receptor, it can be useful to identify endometrial type stroma. And certainly PAX8 could highlight the endometrial type glands if you're in a structure like the bowel, where you would not ordinarily find PAX8 positivity. Sometimes we don't find both of those. We only see features that suggest endometriosis, areas of scarring, fibrosis, or hemosiderin-laden macrophages, or acute hemorrhage, slightly altered stroma that may or may not be completely convincing for endometrial type stroma. When we think about complications, these are quite dependent on the site. Certainly, organ dysfunction can be related to endometriosis, both in the ovary or in the uterus, but in other organs as well, and can create mass effects or can create bleeding, scarring, or other problems with the normal functioning of those organs. And as endometriosis is widespread or in the wrong location, certainly neoplasia can occur in endometriosis. The development of various endometrioid-type cancers can arise in consequence of endometriosis over the long term. In terms of differential diagnosis, other things that can produce cystic spaces, endosalpingiosis, not usually associated with endometrial type stroma, some peritoneal inclusion cysts or other benign inclusions. Hemorrhage can be seen secondary to trauma or other sorts of injuries. And then other causes for mass effect, cancers, et cetera, hamartomas, and so forth. That's a real quick run through. I just wanted to show you maybe some of the thinking behind what causes endometriosis or where it comes from, because this is a really unique circumstance where a normal tissue or seemingly normal tissue that is benign nevertheless metastasizes or appears in other locations than where it is normally occurring. And there are a variety of hypotheses that have been projected to explain how endometriosis can occur in distant sites like the spinal cord or bone marrow or other locations. Certainly for the more common locations, it's possible that it could arise from either Mullerian rests or mesothelium through either metaplastic or some sort of an induced fashion. It's also possible, and this theory has been shown with some experimental evidence to be a highly possible location, that anything that leads to retrograde menstruation or traumatic implantation of endometrial tissue can potentially lead to endometriosis. So, cervical stenosis with retrograde menstruation could be a predisposing factor for pelvic involvement by endometriosis. Likewise, we see endometriosis occasionally occurring following cesarean section or laparoscopic surgery, where the endometrial type tissue gets mechanically deposited in association with that. Other theories that have been advanced include, the development from hematopoietic stem cells or other precursors. Hematogenous or lymphatic spread has also been hypothesized and may explain the appearance in lymph nodes and other more distant locations. And there also appear to be some hormonal, environmental, and genetic factors, even epigenetic factors, heritable issues that raise the likelihood, because it appears that the endometrial tissue requires some additional dysfunctional cofactors or other features to be present in order for it to implant or develop in these other sites outside of the uterus. So all of these are factors that play into it and may explain some of the features, but not all circumstances. And it may, in fact, be a multifactorial or potentially multi-etiologic sources that could lead to it. So I just thought I'd show you a few additional pictures. This is an example of endometriosis in the skin. And as you can see here, it's creating a bulging mass effect. Possibly this is in a prior trocar site from laparoscopic surgery. Here's what you'd see under the microscope. The skin surface here along the top, and irregular glandular spaces with some associated hemorrhage, and the stroma that we've described, some luminal features. Because this endometrial tissue can't slough in the normal manner, it tends to accumulate inflammatory products, because as it tries to cycle, it can't cycle and slough and regenerate in quite the same manner as it would in the normal anatomic distribution. Now we illustrated an example also where relatively little stroma, but a lot of other types of stromal reaction. Here in the sort of peritonealized surfaces, you can see these glandular spaces with a real minimal amount of stroma, but a lot of sort of desmoplastic reaction. This might easily mimic cancer, particularly if you had some degree of atypia, but the association of the stroma, the hemorrhage, and the usually quite bland cytologic features should help you to exclude metastatic neoplasia. Some cases we've seen in the bowel, such as this, can be quite florid, extension up into the surface, but involving really all levels of the bowel wall, as you can see here in the muscularis and out onto the serosa. This is not likely to be an invasive process, but seems to be more likely to be hematogenous or lymphatic spread in this circumstance. Now, treatment for this often involves some measure of hormonal manipulation, and that can be effective in some circumstances, but it can also produce its own sort of response. So here's a patient who was on birth control pills, and the glandular spaces are quite minimalized here. You can see these very atrophic glandular spaces, but surrounding the glands is this very florid decidual reaction due to the progestational component of the medication that she was taking. And so a decidual reaction may in some ways help to minimize, but might also augment the symptoms from this circumstance. As you can see here, there's also a lot of edema associated with this tissue as well. So our final diagnosis on today's case is endometriosis involving the bowel mucosa, and not a surprise in that regard. If you like this, we do hope that you'll hit the like button. That helps other people to find our videos. And please subscribe so that you'll be sure to catch future releases from our channel. We enjoy doing these and hope that they're useful to you in your practice and help others to understand more about the diseases that we are covering in this channel. So until next time, thanks so much for joining me.